Hello everyone, this is Dr. Ankita Singh, Reader, Department of Oral Pathology and Microbiology, Babu Banarsidass College of Dental Sciences, Lucknow. Today's lecture is on verrucous carcinoma. Verrucous carcinoma is also called Ackermann tumor. It is a warty variant of squamous cell carcinoma. It is predominantly exophytic overgrowth of well-differentiated keratinizing epithelium, having minimal atypia and with locally destructive pushing margins at its interface with underlying connective tissue. It is first described by Ackermann in 1948. Clinical features: it is generally seen in elderly patients. Mean age is 60 to 70 years. Nearly 75% of lesions developing in males. Most commonly, it is seen in buccal mucosa, gingiva, or alveolar ridge, although palate and floor of the mouth are occasionally involved. It appears as exophytic papillary with pebbly surface, which is sometimes covered with white leukoplakic film. Lesions commonly have rugae-like folds with deep clefts between them. Lesions of the buccal mucosa may become quite extensive before involvement of deeper contiguous structures. Lesions of the mandibular ridge or gingiva grow into the overlying soft tissue and rapidly become fixed to the periosteum, gradually invading and destroying the mandible. So this is the picture which shows clinical appearance of verrucous carcinoma. Regional lymph nodes, it become tender and enlarged, simulating metastatic tumor, but this node involvement is usually inflammatory. Common complaints are pain and difficulty in mastication. Bleeding is rare. It has been reported that a very high percentage of patients with this disease are tobacco chewers. A small number of patients give no such history, but instead use snuff or smoke tobacco heavily or ill-fitting dentures. Growth, it is usually slow and metastases occur late if at all present. It may become more aggressive if irradiated. Histopath features. Histology may be extremely deceptive and it may be mistaken for papilloma or benign epithelial hyperplasia. So there is marked epithelial proliferation with downward growth of epithelium into the connective tissue, but usually without pattern of true invasion. Like in the picture also, you can see a well-differentiated hyperplastic epithelium. Epithelium is organized into bulbous rete ridges. You can see it over here. And it shows little mitotic activity, pleomorphism, or hyperchromatism. Characteristically, cleft-like spaces with thick layer of parakeratin is present. So you can see in between parakeratin plugging, which occurs extending into the epithelium. And these features constitute hallmark of verrucous carcinoma. The basement membrane will often appear intact. When the lesion becomes infected, focal intraepithelial abscess are often seen. Chronic inflammatory cell infiltration in the underlying connective tissue may or may not be present. Unfortunately, diagnosis of verrucous carcinoma is often difficult even when biopsy specimen is generous, and the pathologist will sometimes request for second biopsy. So that is all for your lecture. Thank you.